Yeah, continue.
All right, well, welcome everybody. Thank you so much for being here with us this morning. My name is Corlin Holfish. I am a social worker. I am part of the New Jersey HDSA chapter board, and I also work at Cooper University Hospital in our neurology department, and both of our physician speakers today are part of our department. So I'll be introducing them later. Before we go any further, I did want to take a moment for us to have a moment of silence, as we always do at all of our events, to remember why we do this work and to remember those who have suffered and are still suffering. Thank you. So this presentation today is coming to you, is funded by the Huntington's Disease Society of America with support from Genentech and from Unicure. So we thank them and appreciate what they do. I'm going to get started by sharing my screen. I'm going to do a couple of slides, and then I'm going to hand it over to Stacy Waterman, who is our board president. So bear with me while I work this out.
I'm glad you're handling that.
There we go. As many times as I do this, I have to remember.
You and me both.
All right, so on this slide here, we have our board members. Many of whom may be on this call today. So we want to thank everybody for everybody's participation. And then this is our mission, to improve the lives of everyone affected by Huntington's disease and their families. Our vision is a world free of Huntington's disease. And then part of what we do is to support the Huntington's Disease Society of America mission to serve HD families through support groups, social workers, building community, and supporting youth. And hopefully, we make ourselves very accessible within the community. I'm hopeful that if you ever need anybody on the board for anything, that you are able to find one of us. We also work hard to advocate for change, and Stacy's going to talk a little bit more about that, as well as helping to provide education for individuals, professionals, the community, as we are doing today. We also work to build awareness with law enforcement, emergency responders, the medical community, schools, congressional people, and we also work to raise funds through different events that we do. Hopefully, you've maybe been to our walk or our run, our golf event. We have a lot of really fantastic things, and a lot of that money then gets put toward research because our main goal here is to make sure that that we can end this disease. And what I also wanted to add today that is new, we are proudly announcing the Dan Snyder Memorial Scholarship for New Jersey residents so that they can attend convention this year. So super exciting. Convention is supposed to be in person this year in Atlanta for those who can attend. And so we would like to honor Dr. Snyder by providing $1,000 toward expenses of attending convention. So part of the requirements are that you do need to live in New Jersey, and preference may be given to families who have not previously attended convention. So if you have any questions about how to apply, you can go to newjersey.hdsa.org and click on the link there, or you can certainly just contact any of the board members and we're happy to give you information on how to do that. I'm going to stop sharing for just a second to make sure there's nobody else I need to let in.
Thank you. Thank you for mentioning that.
Oh, you're very
welcome. That is hot off the press. And the e-blast will go out next week about it, but it's already up on the website, like you mentioned. So thank you.
Well, thank you, Stacy. All right, so I'm going to again go back to sharing my screen, and Stacy's going to take it over from here. Okay. So let me introduce to you then Dr. Stacy Waterman, who is our board president, and is going to be talking to us about advocacy. All right.
All right. Like Rowan said, one of the main focuses is really advocating for change. When it comes to Huntington's disease, we're the ones who are the experts. We know how it impacts our family. We know how it impacts us, and they don't. Members of Congress hear from people in their constituents all the time. We have to be the ones who have the loud voice and really work together to advocate for change. And that's what we're doing on the board. We actually have an advocacy and education committee that Denise Zuko and I chair along with Corlin. And so I'm going to talk about a lot of the work that we've been doing through there. And Denise is on the NJ Cure HD Board of Directors. So basically, what is advocacy? It's speaking up politically, educating, raising awareness. We know more about HD than anyone. So we need to be the ones that educate Congress and the general public too. They won't act unless they hear from us. And the general public won't take notice unless we raise our voices together. And so when we first started talking to representatives of Congress, members of the Senate, the New Jersey Senate, I started to put together a family tree. And it's crazy when you start looking at, wow, these are so many people that are impacted. The dark color means they had HD, and the shaded one is at risk. So it's pretty prevalent in my family, and it's the reason why I do what I do. It's crazy when you look at it like that. So when we advocate, we share our stories, and everyone who does it differently. You know, because people are comfortable. Some people are comfortable talking about it, and other people aren't. And so, what you choose to do is completely up to you. You know, you could send emails to Congress. You can talk to members of Congress, members of the Senate. It's really up to you how you want to approach it. Me, I don't care. I talk to everyone. So why am I an advocate? My family, my HD family. I have 2 children, and my daughter is 24, 25 next month, and she's at risk, and my son is negative. He was tested in utero, and thank God he's negative. I have my doctorate from NYU in neuro immunotoxicology, so I'm a geeky scientist. So I love all the science and the research that's going on, and I'm looking forward to the presentations that are coming up. And basically, I found out 25 years ago. My grandmother shook. We thought she had Parkinson's disease. My mom started showing symptoms, but she was never tested because she said that there was no treatment and no cure, and she couldn't live with it if that's what she had. And so I didn't push. I was a good daughter and kind of just went along with her and let her think she had MS because that was easier for her to deal with. So when she had come, when my daughter was born, my mom came and stayed with me, and I noticed that she was shaking and couldn't do things that it took her 45 minutes to open a can of soup for me. And I thought, yeah, something's not right. So I found out that it was HD because she kind of distanced herself from her family because they were crazy, but it was really HD crazy that I think so many people know and, have experienced. This disease has destroyed my family. I've lost so many, my grandfather, my grandmother, my great grandfather, my mom, my aunt, my 2 cousins. So it's hit me hard. But I'm one of those, the glasses half full kind of person. When I found out, I kind of did all the responsible things. I got long-term health, long-term care insurance. I got life insurance. And then I just kind of put it in a box and put it on a shelf. And I had faith in the science that by the time I got to be symptomatic, there would be something for me. So I just kind of decided I was going to live every day to the fullest. I lived in 3 countries. I traveled over the world. I skydived in New Zealand. I joined the board when I couldn't work anymore because I was forgetting things. I worked in the oil industry and I was just forgetting too many things. So I decided to really make a difference for me and my family by working with the board. So why do we care about the Parity Act? The Parity Act has been around for 12, we've been working to get this passed for, I want to say 12 to 15 years, a long time. It sits in both the Senate and the House. And what it does is currently the way it works is once you're declared disabled, you have a 2-year waiting period before you can get Medicare benefits. And so the Parity Act gets rid of that waiting period. And at the end of last year, ALS was able to get their was able to get the 2-year period waived. So we're trying to leverage off of that as much because we're saying, HD is like MS, ALS, and Parkinson's kind of all rolled up into one. So we're really trying to push and we're having a focused approach in how we try to get this passed. So it's individuals contact targeted elected officials, tell their story, and ask members of Congress to be co-sponsors. And there's more. And it sits in the House and the Senate. In the House, it was actually Representative Bill Pascrell from New Jersey who co-sponsored it. Bill Pascrell Jr., sorry. He co-sponsored it, and it sits in the Ways and Means Committee. And we have been working with him very closely and his staffers and trying to get them to push other members in the House to support it as well. In the Senate, we don't have any New Jersey senators that have co-sponsored yet, but we've met with Senator Booker, we've met with Senator Pinocchio, we've sent with Senator Menendez and a few. And we're hitting that hard this year too. They sit in different places. In the House, it sits in the Ways and Means Committee, and the Senate bill sits in the Finance Committee. And if you want to get involved with us, like I said, you could do as much or as little as you want. HDSA has this so well organized. If you go on the website for hdsa.org and click on the advocacy section, that's what will come up. 2 years is too long past the Parity Act. And all you do, literally, it will take not even 5 minutes because I did it for all my family members. You click on the link and you put in your information, and basically you're sending a message about the Parity Act to the members of Congress. So we're encouraging everyone to do it because it's very easy to do. It only takes a minute. And you could also join the HD Advocacy Caucus that's set up by National. And what that is it's a group of advocates. Some people have been advocating for years and some have just joined, some young, some old, and it's across the country. And we all kind of talk everything is very targeted, and it's targeted approaches to the House and Senate representatives. So what can you do to help us? You could go on the HDSA website and become an e-advocate. All of the members of Congress, and they're huge on social media. So we're really pushing that everybody use social media too to stand for them and advocate for HD. You can get involved by joining our New Jersey advocacy team on the caucus that I talked about before. And then there's also going to be a New Jersey grassroots initiative that's coming out, and it's going to help us get money for our New Jersey New Jersey clinics that serve over 400 HD families in New Jersey. So more details to follow via email next week on that one. That's hot off the press for us too.
Great, thank you so much, Stacy. And I'm just gonna go through the last few slides here. So we do also maintain a resource guide for our New Jersey families, which covers all sorts of information, social service agencies, doctors who treat HD in New Jersey, our new Center of Excellence in New Jersey, driving evaluations, swallow studies. If you have anything you would like added to our resource guide, or if you ever come up with anything, if you call a phone number and it doesn't seem to be doing what you need it to do, please let me know. I'm always happy to make changes to the resource guide. And you can find it at newjersey.hdsa.org. And then it's really important that we continue our work in raising awareness, attending fundraising and educational events. And we're always looking for people to volunteer, to potentially join our board, join a committee, be in a support group, advocate. As Stacy said, it's very easy. HDSA makes it very easy for us to contact our Congress people. If you go to the website, they have some direct contacts. Some of the things literally takes 30 seconds to send something to make sure that your congressperson knows how you feel and what you feel like we need. So we have Amaryllis cells every fall. Thanks, Mary Claire. And a really easy thing to do to support the New Jersey chapter specifically is to go to smile.amazon.com. If Amazon's something you use regularly, you can select the HDSA New Jersey chapter to receive funds, donations every time that you make an order with them. So that's another really easy way to support. And so our upcoming events, hopefully, we keep getting closer and closer to doing more things in person. And this year we're really excited. Our Jersey Shore Team Hope 5K run and walk will again be taking place at Bar A in Lake Como, New Jersey. That'll be on April 30th. And also our Team Hope walk, which we did do in person this year, which was fantastic. And Oktoberfest, that will again be at Roosevelt Field in Edison in October. So hopefully we will see you there. And here's just some ways to get in touch with us. So again, online, Facebook, Twitter, Instagram, feel free to, again, reach out to any board member. We're always happy to help.
Thank you.
So I will again stop sharing that. Oops.
Thank you.
Janet back in. Here we go. And I apologize if you heard my animals being noisy. Forgot to mute before I shared my screen. So thank you for that. So I'm going to go ahead and introduce Dr. Amy Coulter, who I see just came on our screen here. So she's going to be talking to us about some general symptoms and treatment in HD. So we appreciate you being here this morning. I'm going to go ahead and actually put a pin, I believe I remember how to do that, on you. There you go. Hello. And I'm going to mute myself. So thank you again for being here, and we're really looking forward to hearing what you have to say. Oh, and you should be able to share your screen.
Okay. Let's see. Not at all. Desktop share. This is a mess. I'm sorry. I hope. Can you see that? No? Yes?
I can
Can you
see you.
You can see me, but not my screen?
No. I mean, yes, I can see you, but not your screen.
Okay, that's no problem. And I'm gonna apologize also in advance for if you hear my dog, because he is running around like a crazy person. All right, let me see what is the matter with the share screen thing.
Mine's downstairs.
So actually, while you're getting that set up, I can let everybody know, I can flesh out a little bit more information about the scholarship to convention that National provides. And that's for a family of up to 4. And it covers travel, a hotel, convention expenses, and tickets to the gala. So if you know a family who's interested in applying for that, they can also go not to our New Jersey site, but to just hdsa.org. And there's a way to apply for that there. So again, really exciting that convention will be again in person this year. It's going to be a little bit toned down, a little smaller to allow for some social distancing. And so there will still be some precautions in place, but still it'll be really fantastic to have that opportunity. And again, it'll be in Atlanta this year. So that's also very exciting. And so in terms of other things that we have coming up, we are going to be working on our statewide education day in May. That I'm hoping to be working a little bit with our new Center of Excellence to get that planned, because that's a little bit of what they do as well, is that they have an education day that that every Center of Excellence does every year. So I'm hoping we can partner with them to bring you something, and we'll see if we can do that in person. Hopefully that's something that we can somehow pull off, because I think it's something that we do all miss being able to do.
Yeah, I agree. We're trying to find an outdoor venue that we can use. So we've got some suggestions. We talked about it on our meeting last night,
Excellent.
our last board meeting.
All right.
Yeah.
And Dr. Coulter, would it be helpful if you would you want me to, if you could
To
send me
send you my PowerPoint?
Yeah, I might be able to. If you send them here, let me send you in my chat.
And I do thank you for mentioning about the other scholarship too. I think we're going to end up, there are going to be some virtual sessions as well, right? At convention this year too.
Yes. Yes.
Yeah. So for people who can't make it.
All right, Dr. Coulter, I'm sending you my Gmail account because that
Okay.
seems to allow that to go through a little better.
Sorry.
No, that's the joy.
No, when Corlin sent me an email last night about 6. Do you want me to run your slides? I'm like, oh my God, yes, I'll send them.
Did you send?
I typed it into the chat.
Into the chat, so I have to go back here. Hold on, chat.
And I could probably
Chat.
send-
Okay, hold on, coming.
No, it's okay.
Okay, insert.
Yeah, I'm going to pause our ring again. Okay. Stacey, I'm going to make you the host. Yes. Okay. And I'm going to go ahead. Oh, I'm going to mute myself first, and then I'm going to share my screen.
Okay, great. You can see that, everybody?
Yes.
Okay, good. Okay, wait, so Corlin, do I have to tell you when I want the slide to advance? Yes?
Yes.
Okay. Okay, so I am just gonna, I think what you've been talking about just now is probably a good segue into this talk, which is sort of an overview of symptoms and available treatments of Huntington's disease. But I think that obviously for most of you on this conference, you do talk about it, you do feel comfortable talking about it, but there are so many families that I see where they do not, or there are a lot of misconceptions about what are symptoms of Huntington's disease and when do you actually have Huntington's disease, and are there things that can be done about it, or is this just, you know, a death sentence and you're just waiting for time for you to get out of this world? And so I think that it is our job as physicians and other people that work with families with Huntington's disease to help to clarify this and make it so that it is not such a secret, because the longer it stays secret and the longer people don't talk about it and don't understand it, the longer it's going to be for us to find a cure or find better therapies for the disease, because we need people to, as Dr. McGarry will talk about later, to participate in clinical trials to get drugs FDA approved that can be used to slow the progression, but they can't be in a trial if they don't know anything about the disease or are not willing to talk about it. So this will probably not be a lot of new information for most of you, but I want to sort of go over it anyway. Next slide. So the things that we look for in terms of Huntington's disease are problems with movement, problems with mood, and problems with memory. And the thing to keep in mind is that it is not until the movement symptoms are actually evident that we make a diagnosis of Huntington's disease. So certainly people have other symptoms before they develop any kind of involuntary movement. But in order to make a clinical diagnosis of Huntington's disease, we wait for there to be some abnormalities of movement. And then we say that the person does have Huntington's disease, not just that they're at risk or they're gene positive, but they actually do have the disease. And the movement disorder, it can be almost anything. So it's not, even though the disease was originally called Huntington's chorea, which describes the wiggly, fidgety movements that you see with Huntington's disease. It is not just that. There's slowness of movement, there's trouble sustaining muscle tone, which may be why some people drop things. It's not that they're clumsy, it's just that their muscles won't sustain that tension, and so things will fall out of their hand. There may be some muscle spasms or abnormal positions that the body gets moved into. There may be things that look like Parkinson's disease, and there may be troubles with balance. So you can see almost anything with Huntington's disease. It's not just the chorea. The mood disorder also can be anything that you can imagine. People can be irritable, people can be depressed, anxious, apathetic. So they can have problems with obsessive compulsive disorder. So we're constantly asking people about their mood, about their mobility, and about memory issues. If they're having trouble with their thinking, if they're having trouble keeping track of things, so that we can help to manage all those symptoms. Next slide. Okay, so there are definitely things that may happen before you actually get diagnosed with Huntington's disease. And it's hard to say. So again, it's hard to say when Huntington's actually starts. The studies that have been done that sort of followed people longitudinally, people that were at risk, people that didn't want to know their gene status, we do see that there may be some changes in their thinking in a lot of people way before they get a diagnosis of Huntington's disease. Behavioral problems also may happen way before you get a diagnosis of Huntington's disease. But again, it's hard to know what to attribute to the HD and what is sort of part of being human. Like, let's use depression as an example. So many people have depression. And if you have had depression since you were 20, and now you're 50 years old and you're starting to have motor symptoms of Huntington's disease, do we say that that depression was all from Huntington's disease? Or do we say you had depression and now you have Huntington's disease too? It's hard to sort that out. So I think sort of looking at those mood symptoms and cognitive changes, it's hard to know for sure whether they are in fact early signs of Huntington's disease or signs of something else. Next slide. So the motor disturbance that we see can be clumsiness, can be trouble with fine motor movements, things like handwriting, things like clasping your clasp if you're putting on a necklace, putting on your jewelry, trying to use a screwdriver, things that need actual sort of really careful attention to detail with motor movements. You may have trouble with your balance. We talked about the inability to sustain certain voluntary movements, so letting go when you should be holding on. There may be difficulty controlling your tongue or your diaphragm, which is the muscle involved in breathing, so that you have trouble with your speech. You can have trouble with your swallowing. Your voice may not have the same musical quality that it used to have, so it comes out more sort of in and out, where there's a rapid speech and then a pause, or it may be louder than usual, or it may be softer than usual. So the quality of someone's voice when they have Huntington's disease can be changed because of the motor symptoms of Huntington's. Next slide. The psychiatric disorder is really very unpredictable. The depression is the thing that we worry about the most, because we know that suicidality is much more common in people with Huntington's disease than it is in people with other neurodegenerative diseases. So I'm sure when you see your doctor, they're constantly asking you questions about your mood, about depression, about whether you've ever thought of ending your life, any kind of suicidal ideation, because we know that that is a risk in Huntington's disease. But suicidality is not always because of depression. It can also be because of impulsivity, that sometimes something goes wrong one day and you just decide, okay, I don't want to live anymore, and you kill yourself, and you haven't been depressed before that. So it's not just depression that makes people commit suicide, but we ask about all these things, about depression, about mania. Do you have like excessive energy? Are you not sleeping well? Do you have symptoms of OCD, where you are constantly thinking about things that you can't get out of your head, or doing things over and over again? Psychosis is not that common, so people don't often have hallucinations or paranoia, but it can be part of the psychiatric disorder of Huntington's disease, and so your doctor is going to want to know about that. There are some more specific things related to Huntington's disease, which have to do with what we call executive function, sort of planning things and being able to suppress things. So the executive function in our brain makes us not say out loud. If we think someone's sweater is really ugly, we don't say to them, gosh, that sweater is really, really ugly. We just say nothing. But people who have problems with their executive functioning parts of their brain, which is their frontal lobes, typically, they will just spit out whatever they think. And it may not always be as nice or put in as nice a way as possible. They may do things more impulsively, so they don't wait and they don't think things through, they just do it. They may do things more obsessively, that they're constantly doing things over and over again. And all of these things, and also they can be apathetic, which is sort of the opposite of all this, where they just want to do nothing. Where you just, and I think actually this is probably a problem for a lot of us since COVID has been going on, that you just don't have any motivation to do things, that you just, you're sort of happy sitting around, and even though there's plenty of things on your to-do list that need to get done, you don't have the motivation to do that. And this, although the other symptoms of Huntington's disease may be more in your face bothersome, the apathy part of it is also very bothersome. It's so hard to get somebody motivated who is apathetic, who just doesn't care, doesn't want to do things, doesn't get enjoyment from the things that they used to enjoy. And so you've planned, we're going to the movies, we've planned to see this movie, we've been looking forward to when this movie comes out. And then the day of the movie comes and the person just says, no, I'm not going, I don't feel like it. And you've been trying to push them to do it and they just won't do it. It's extremely frustrating, and it causes, all of these things cause stress in terms of the family, in terms of your social interactions with other people, and can cause problems with job function. If you don't feel like, if I went into work and I said, I just don't feel like seeing any patients today, I don't think I would keep my job for very long. So you have to have that motivation to do things in order to keep your employment and to keep your friends. So, and other people trying to push you is not necessarily helpful. So it can be very, very frustrating. Next slide. The neurobehavioral changes that we see, people can become more irritable. They can find fault with other people. They can be blaming you for things or complaining about things. They can be more suspicious and more impulsive. So impulsiveness is where, like, let's say that you decide that you need to have a Diet Coke and it's the middle of the night, and you just walk out of the house. It's wintertime, you don't put your coat on, you just decide to leave. That kind of impulsivity can be a problem, that you can't make yourself stop, even though you know that you should. And again, that lack of interest in things is a huge issue when it happens. Next slide. Other things we talked about: anxiety, depression, compulsive behaviors. The people can have hostile outbursts. They can have temper control problems. So definitely asking if this is going on at home, and if this is a problem, if this is a change from a personality that was never like that before, it's important to talk about it. It's not to brush it under the rug and be embarrassed about it, because nothing can be done if you don't say these things out loud, if you don't mention them. So you want to be honest with your physician so that we can work together to try and help to improve things. Sleep disturbance also can be a problem in Huntington's disease, and sleep is so important. When you sleep, it is the time that your brain actually sort of detoxifies itself. It gets all the junk out of it so that it's cleaned up for the next day. It's like sleeping is like flushing the toilet to get all that stuff out. So we need to get good sleep. All of us do. But especially people with neurodegenerative disease, because the less sleep you get, the more irritable you get, the less clear your thinking is. And we want to make sure, and the worse your mood is. So we want to make sure that all your sleep is as good as it can possibly be in order to keep you feeling good throughout the day. Next slide. The cognitive decline is forgetfulness, usually difficulty paying attention. and difficulty multitasking. So although we all think, I think, that if we're doing two things at once, that we're actually being more efficient. But the truth is that that is not true, that it's much more efficient to finish one task and then move on to the other. But this sort of idea that we should be multitasking all the time is so ingrained in us that we all are multitasking all the time. But as the brain changes in Huntington's progress, it is much, much harder to multitask, and you lose track of what you're doing in the task that you're doing and the other task that you're doing. And it makes it so that nothing gets completed. So you really want to make sure that when symptoms like this start, that you really focus on one task only, finish it, and then move on to the next, not trying to multitask. It's the simplest terms, like if you're doing the laundry and then you're upstairs cooking, you forget that you put the laundry in and you don't remember to go back to it and switch it into the dryer. And then you figure out that you did the laundry 2 days ago and it's still in the washer, and now you have to wash it again because it's all stinky. So that kind of thing is very inefficient, and it's better to just focus on the one task at a time. Next slide. So as the disease progresses and the cognitive symptoms get worse, it becomes harder to learn new information. So this is why when people are, this I guess comes in handy when you're applying for disability, because the disability questionnaires always ask if vocational rehab would be helpful. People with Huntington's have a hard time learning new information. This is also why people may have trouble with their job if something switches, or the way that they do things has to switch. It's hard for them to get used to a new system, whether it's a new computer system or a new organizational way of doing things at work. So it may make it hard for them to adapt to changes in the workplace. They may have more trouble with language, and which makes it harder to communicate with other people. And again, that whole frontal idea of planning things out and figuring out how to do things in a stepwise progression gets more difficult. And so it's harder to figure out how to do a more complicated task that has multiple steps involved in it. Next slide. In advanced disease, as those of you who've had family members pass away with Huntington's disease, it can progress to progressive difficulty with movement. So people lose their ability to balance, their ability to walk, their speech can get more disordered. So it's hard to verbally communicate with them, and their swallowing may be disordered also. So it becomes hard for them to eat. They lose the ability to care for themselves, to communicate, and to maintain their nutritional status. The nutrition is actually, next slide. I think I have a slide on this too. Okay, so next slide again. And one more. Okay. So Huntington's disease, as you know, is an autosomal dominant disease. That means everybody who has Huntington's disease, who has children, each child has a 50-50 chance of getting the abnormal gene. And the gene is a repeated sequence of CAG, which are nucleotides on the DNA stretch that is on chromosome 4. And when you get the DNA test for Huntington's disease, it comes back and it tells you the number of repeats that you have. And you have 2 copies of each gene. So one copy will, if you have Huntington's disease, is typically going to be over 40. And the other copy, which is normal, typically for most people is something in the teens. So it's not even close to 30, but it can, like in the 20s, is still considered normal as well. So you have the abnormal gene. That does not mean that you have Huntington's disease. That gene is there from the time you are born till the time you die, but it doesn't make a diagnosis. It just tells you that you're gene positive. So we wait, as I said before, we wait until people have some problem with their movements in order to make that diagnosis. Next slide. This is, the positive gene test indicates that you will get the disease if you live long enough. Some people don't live long enough. Some people, the age at onset of symptoms of Huntington's disease is very variable. And although we look at that CAG repeat number to try and help us get information, and we know that very, very long CAG repeat numbers, like in the 80s, typically give us a young onset of Huntington's, like juvenile Huntington's disease. But the truth is, most of my patients have repeat lengths in the 40s, and some of them have gotten symptomatic in their 20s, and some of them have gotten symptomatic in their 70s. So it isn't like anybody can look at that number and tell you, yes, you're going to get symptoms at 56. It doesn't work that way. The gene test tells you that you have the gene, and that you'll get Huntington's if you live long enough, but you may get hit by a bus before you ever get symptoms. You may have something else that shortens your life that makes it so that you never get symptomatic, or the symptoms may happen so late that it doesn't affect you at all. I've probably told this story before, but the first person that I ever diagnosed with Huntington's disease was 72. And he just had some sort of fidgety movements of his leg. When he would cross his legs, his foot would wiggle around in circles. And nobody thought anything of it until he was in the hospital for some heart problem. And then the doctor said, I think you should see a neurologist about that. And I diagnosed him with Huntington's disease. And he died a couple of years later of a heart attack. So the Huntington's didn't actually impact his life at all. But his children's lives were certainly impacted by it. So the age of onset is completely variable. And that number doesn't tell you specifically anything that is going to let you know exactly when your symptoms are going to happen or what your symptoms are going to be. And the reason that we talk about all the different symptoms, the mood, memory, and movement symptoms, is because they all can be present. Some of them can be present. Some can be problematic at one point in time and then be less problematic as time goes on. So it is sort of a fluctuating thing. And that's why when you go to the doctor's asking you the same questions all the time to assess all of those symptoms and to try and figure out how to make things better as best we can. Next slide. The treatment of Huntington's, this is a very busy slide, but it ideally is a very multidisciplinary approach. So you need a medical doctor, somebody who could potentially prescribe medications to treat the depression, the anxiety, the mood issues, the memory issues. You need psychosocial support. You could need physical therapy, occupational therapy, and speech therapy. You need a genetic counselor. You need other social support systems. So that's why we have support groups and we have other groups to help with that. You may need spiritual assistance. So we advocate if you are a spiritual person and there are other people that are like-minded, to get support from them as well. There isn't any treatment right now that is currently available for everybody that will slow the progression or stop the progression of the disease. So again, support for families like the HDSA provides is there, and we want to take advantage of it as much as possible, because this is a disease that is progressive, and we want to try and make things as easy as possible and as good as possible, so people are living as full a life as possible, despite the fact that they have Huntington's disease. So our goal is to improve quality of life. And as research progresses, then it will be to increase longevity and decrease the side effects of having Huntington's disease. They will try and target progression and symptom relief to try and make all of that better in the future. Next slide. So we do have drugs that treat the involuntary movements, and this is a list of some of the drugs that are available. These are typically all drugs that do something to the dopamine system, because blocking dopamine in the brain, or getting rid of extra dopamine in the brain, can slow down extra movements and can help in terms of suppressing some of the extra choreiform movements that we see. We don't treat the extra movements just because we see them. We only treat them when they're bothersome. So if it's not bothering the person who has it, if it's not interfering with things that they have to do, then it is not necessary to start medicine just because it's there, but only when it is interfering with things. My theory in terms of treating any neurodegenerative disease is that you only treat when you have to treat it. Everybody doesn't have to look perfect, but they have to feel good. So if something is not bothering them, then you don't have to fix it. Next slide. The cognitive symptoms are treated initially non-pharmacologically, trying to simplify tasks, trying to do one thing at a time, not giving, if you want somebody to help you and you're cooking in the kitchen, but you need them to go down to the basement and bring you up a can of tomatoes and a can of green beans, you may not be able to say, go get me this and that in the basement. You may want to say, go get me a can of tomatoes. And then when they come back, go get me a can of green beans, so that they don't have to keep so many things in their head. You don't want to, if they want to get dressed, you don't want to open the closet where there's 20 shirts hanging there and say, what do you want to wear? Maybe you simplify it and you say, do you want to wear this red shirt or this blue shirt? So it's a simplified question, and it's easier for them to answer without getting overwhelmed. The medicines that we have that can treat the memory symptoms and the thinking symptoms are all medicines that are FDA approved to treat Alzheimer's disease. They do seem to work to slow the progression of memory problems in Huntington's disease as well. So we use those medicines in patients with Huntington's disease too, but the medications are designed to slow down the progression. They are not reversing the problem. So when people are starting to have problems with their memory, we put people on these medicines. They typically don't notice improvement. Although I have seen it happen that sometimes they do get somewhat better, but typically it's just making the progression slower, so it doesn't get too bad as time or as fast as it would have otherwise. Next slide. The treatment of the mood disorders in Huntington's disease. Again, there are so many different issues that can happen with mood, and there are no Huntington's disease specific mood medicines. So we use the medicines that are out there to treat anxiety in everybody, depression in everybody, psychosis in everybody, and there is no one drug in any class that is better for Huntington's than another. Sometimes it is helpful in terms of treating mood disorders if somebody else in the family had the same kind of mood disorder and they did well on a certain medicine, then that's a good thing to mention to your doctor, because typically the response to medicine may run in families too. And so you would be more likely to try a medicine that somebody else had done well with, and maybe avoid a medicine that somebody else in the family had had problems with in the past. And that's sort of a good rule of thumb to try. There are tests that can tell for an individual which, say, antidepressants might be better for them or not, based on the way they metabolize medicines. I don't know that all psychiatrists use that testing. I don't know that some of them look at it and go right from that sort of information to what they prescribe. Other people don't believe in it at all and will just sort of work through medicines the way they would have otherwise. But those are tools that we can use if somebody's having trouble finding, say, a good antidepressant. Maybe that kind of information would be more helpful in terms of pointing you to a different medication to try. Next slide. Nutrition for Huntington's disease. As we know, the Huntington's disease typically makes people lose weight. And so our goal is to try and keep people at their normal weight. We don't want them too heavy, but we don't want them too skinny either, because if they're too malnourished, that is a bad sign for the future. So we want them to try and stay at their normal weight. And ways to keep your weight where it should be would be to increase your protein intake. Also to do frequent small meals or snacks, or what we call grazing, which sounds a little awful, but sort of just eating little bits of things all day long rather than trying to increase the size of a meal. So that may be easier to get all the calories in if you do it that way than to actually increase the size of your meals. If there is a problem with swallowing, then this is where we use the speech therapists. We want them to see if there is a problem swallowing certain types of foods or certain sizes of foods, if there is a better consistency of food that would be better, if you need to, take a bite of food and chase it with a drink to be able to safely get it down. So that advice is very, very helpful in terms of keeping people eating safely. It also may be easier to do single consistency foods. So I use like chicken noodle soup as an example of this. The chicken noodle soup, you have chunks of chicken and chunks of vegetables, but you also have that thin broth. And it's hard when you have problems with your swallowing to control all those different things. The thin broth tends to run down your throat faster. And if you're concentrating on trying to chew up the chicken and the vegetables, then you're not concentrating on the fact that the broth is going down and you could start choking. So having it all, like a butternut squash soup where it's all one consistency, or if it was just chicken broth without any noodles and vegetables in it, then that would be fine, because then you only have to concentrate on one thing. Also eating one thing at a time, so you're not putting all your food, not mixing your peas and your mashed potatoes, but eating the mashed potatoes and then eating the peas. Making sure that everything is out of your mouth between bites, so that you don't have extra food in there that might be pocketed between your cheek and your teeth. And then when you're not expecting it, that comes out and you have more to swallow than you thought you would. Also limiting your distractions when eating. So you're just concentrating on eating and not trying to talk while you eat, or not trying to pay attention to watching TV while you eat, is sort of eating mindfully, really, really paying attention to what you're doing when you're eating. It helps you enjoy your food more, but it also helps to keep you safe when you have some trouble with swallowing. Next slide. Physical therapy is hugely important. Exercise is hugely important. So the more you do, the more you stay able to do. So I encourage all my patients to exercise every day. That helps with sleep, that helps with mood, that helps with memory. But if you're starting to have problems with balance or safety, then a physical therapist may be helpful to give you exercises targeted toward helping that, or to help you see if you need to use some kind of assistive device like a cane or a walker or something like that to help with that. So it is really, really important to get into an exercise routine as for all of us, not just people at risk for Huntington's, not just people who have Huntington's, but all of us should be doing exercise on a routine basis to keep us healthy. So that is huge at any stage of the disease. Next slide. Music therapy is another option to try and help. It can improve speech sometimes. Sometimes singing is easier than speaking. And you may be able to sing words that you can't say, which can help you to express yourself more and help with communication. So music is not something to be poo-pooed. Definitely any of you who like turn up the music when nobody's home and sing really loud in the kitchen, and dance with your dog sometimes when no one can see. All those things that's good for your mental health, but it actually helps to improve your speech and can be very, very good for people with Huntington's disease, as well as other problems with language or problems with getting words out. Next slide. And service dogs. I think we tend to think, and I have to say for myself that I was very biased, like how is a service dog going to be helpful for somebody with Huntington's disease? But I have one patient who has a service dog, and the way he walks when he holds on to that dog it's almost normal. It's incredible. And the way he walks when he's not holding on to the dog is like everybody is standing around him, trying to guard him to make sure that he doesn't fall down. So the dog is an incredible asset to him. And I think service dogs are something that can be very, very helpful in Huntington's disease. And also the love and affection that dogs give you is not to be underestimated also, not just for the patient, but for the other people in the house. So I did have a patient who has since passed away who had a service dog, but that service dog was such a big help to his wife. And so I think that they are not to be underestimated, and something, if you are a dog lover, that this is something to look into. And that is a picture of my old dog who is not with us anymore. But he would have been a good service dog if he wasn't kissing you all the time. Okay, next slide. I think that's it. Okay. All right.
That was indeed it.
Any questions that I can answer?
Thank you.
Sure.
It's funny, I was trying to find the presentation. You did a great, excellent job. Every time you talk, I relate to things, it's like when you talk about when you have those days, I'm finally getting better at saying, you know what, I'm watching Netflix today because my brain needs a rest, and it's like, don't bother me. And I kind of do that. And it's funny. When I've forgot about the laundry many times. I was laughing about that. I started putting the light in the hallway outside, the light on. So I remember, all right, there's laundry in there, because the light's on. It's like all these things that you do, like to modify your behavior to deal with the mild symptoms you're having. It's nice to it's like, okay, I'm not nuts. That's why I'm doing this. So it's good. And we had one of our genetics students I don't know if you know Eva, but she's on the board with us. And she was talking about testing when you got tests, and that when people went through the process, the majority of people don't want to know. She said it was like surprising. It was shockingly high. It was like in the 80 or 90% of people that didn't get tested. And I was like thinking of that as well. So.
Yeah, it's very interesting. I think that for the first patient that I diagnosed, he had 10 children, and I had a big family meeting with them because like nobody knew what Huntington's disease was in the family, because they didn't, like, nobody knew that it was in the family until their father was diagnosed. And I assumed that all of them, because they were all adults, would be lining up to get tested, and none of them came.
Yeah.
And that was, I'm going to say it was 25 years ago that I diagnosed him. And now I'm starting to see his children coming to get tested or for treatment. But it's more, they want to get tested because they have children who are ready to have children. And that's why they want to know. So I think until we have something that can slow the progression of the disease, which is why you would want to do the testing so you could benefit from something like that. Whereas to test just because you want to know, most people test for childcare or for having children for family reasons. I've had people test because younger people test because they were trying to make career decisions. But it is true that the majority of people don't get tested.
Yeah. I mean, mine was because I'm Italian. I wanted a large family. That was my reason to do it. And now it's interesting to see like all the in vitro work that's starting now that wasn't around, 25 years ago when I went through it. It's and there's a foundation set up to help people, pay for that as well, so they could have healthy children without knowing whether they're positive or not. It's changing so much. It's good.
Yes.
Great.
No, it is. There are a lot of advances that make it easier, even if you don't want to know that information about yourself.
Yeah.
But
And it's funny. I love your dog. I had somebody ask me about service dogs and where they could find them. So if anybody knows where you can get a service dog, let me know. And
yeah, I think
go ahead after you. No, after you.
I think I found a few resources.
Yeah.
Definitely are weight, and it is a little tricky, but they're out
all
there.
right. Now, if I could just remember who asked me.
Let me know.
I was thinking about your observation in your terrific presentation regarding service dogs, and it makes a certain amount of neuroscientific sense that a service dog would be so useful. Because
I get that. My dog sits on my lap when I'm sad, and she's huge.
Well, they have this sort of radar for your internal state, Stacy. That's right. They're expert at that, better than humans even in many instances. And they also have this ability in a service context to reorient attention, because you have this sense that the dog is always with you. And so you're sort of orienting to the dog on a regular basis. And though you may be distracted, it can reorient you. You may be distracted. They're very vigilant when they're well trained, even just as a matter of training any dog. They tend to be very vigilant for something they like my dog, who's probably hovering, waiting for a treat by the pantry. So there's this quality they have where they can redirect your day. And I also tend to think there might be reason, this is speculation, but from a scientific standpoint, there might be something about the sensory feedback you either get from your limb holding the leash or the dog against your leg, or however they train them to help guide you. There might be something about the dog's representation in your spatial environment or in a tactile way touching you that has some type of feedback quality. So, when you think about dystonia being part of the phenotype evolution in Huntington's, it would make sense that there might be some dystonic relief quality, almost like a sensory trick to such a thing. So it'd be an interesting question to ask from a scientific standpoint, even. Other than that, dogs rule, and everyone knows that.
See, we're nerds.
Yeah, I think it's
Geeky
fascinating.
nerd.
Anytime you can engage science and demonstrate that there's something simple and beautiful that makes sense, like a relationship with a service animal. I'm sure someone's thought about this scientifically, but I'm just sort of musing. I don't mean to be tangential, sorry.
Right. No, I think that's an excellent point. And I just want to thank you, Dr. Coulter, for your time this morning. Again, Dr.
Absolutely.
Coulter is the director of our movement disorder program at Cooper. So thank you again. All right, and so we are now going to get started with Dr. Andrew McGarry, who is also an attending physician at Cooper in our neurological department. And so I think you should be able to share your slides, but let me know if you cannot.
All right, let's give it a try. We should
Good
all
luck.
be this.
Look at that. That's not fair.
We'll go slideshow, play from start. All right. Oh, can everyone see that?
Yes.
All right. If I make that smaller, I guess it's in the presentation view now. So let's get out of that just so it's nicer. All right, cool. Thank you everyone for your time and your attention. And Amy, it is such a good talk. This is always fun to talk about. So in the setting where there's a lot in the pike and a lot of reasons to be optimistic, a lot of that focus has been on the central nervous system, which is the brain primarily and the spinal cord. And I wanted to draw a brief attention to the fact that there's a lot more to think about. And that might be very important because if we think about therapies that will arrive eventually for the brain that are meant to modify the disease, the brain may not be the only target. So we should talk a little bit today about treatment approaches for things outside of the nervous system. So if you go all the way back to 1872, George Huntington, when he described Huntington's disease in a surprisingly brief treatise that he gave to a medical society that is still beautifully written. I mean, he had to have been a phenomenal neurologist for a variety of reasons, but he was very observant. And I think he described it as well as he could, primarily from a motor standpoint. And so even since then, since its sort of recognition, there's a rightful emphasis on changes in the central nervous system and the nervous system in general. Now, what's weird about that scientifically, when you think just even for a minute, is you know that Huntington is expressed everywhere. So mutant Huntington appears in some way throughout the body. And so it's always been a mystery in a couple of clear ways, why it takes so long, for one thing. How is it you can have the gene inherited at birth and have 3 decades go by or 4 decades go by before there's some motor, what we call phenoconversion, which is a fancy word for you have symptoms. There's something visible motorically. Though, as you heard Amy say, you can have non-motor problems before then, and people commonly do. And even before that, there's imaging changes that are visible in cortical thickness, so the outer layer of the brain, and white matter. So you have this very long evolution, which is one of the mysteries that's still being untangled. And the second one in this vein is, if the protein of interest is expressed everywhere, aren't there problems elsewhere in the body? And this has gradually gotten more attention. And I think just as rightfully so, because you can imagine a treatment approach that would have fronts in multiple organs. So you'd be going after the brain, rightfully. You might end up going after the liver or the heart or even the immune system. So this could get very interesting. And so the data that sort of justified this consideration includes changes in white blood cells. So inflammatory markers suggesting that there's a low level of inflammation, whether that's specifically active or not. There's these markers that are being either expressed for some reason or aberrantly regulated. Muscle, so you can look at muscle and see that a lot of the main energetic machinery in the muscle is not normal. And that's been known for a while, both in animal models and humans. The liver, so you can look and see indices of liver damage even in humans. It's subtle. It's not a huge body of literature, but there's reason to believe that the liver may also be dysfunctional. And even some of our own work on the metabolome, which is the set of molecules that are involved in all the metabolic processes in the body, suggests that there's metabolic defects potentially in the liver. And we have a data set that we're about to publish, well, I hope in the coming months, so soon, comparing people who progress slowly and people who progress quickly. And we're seeing things that suggest that there might be problems in the liver more than previously recognized. So to be continued, but it looks like the liver might be a potential target in some way. And then the heart. And the evidence in this regard, there's a few papers in this topic. The investigators from the CREST-E study, including Diana Rosas, Steve Hirsch, they published a paper a little while back looking at cardiac function in their study. And they saw that the heart rate tended to be lower. And there was a tendency to have changes on the ECG. So the ECG, when they put the stickies on you and they get out that piece of paper, it's usually pink, has the squiggly lines on it. Those lines reflect what the heart is doing as it pumps. And you can infer based on the movement of electricity through the heart tissue, whether the different points of communication are timely and efficient. That's what an ECG tells you. And you can also infer whether the heart is struggling in some way or whether it's damaged, even regionally. So an ECG is a very useful data set. And it looks like there's more abnormalities in people as they progress. And so there's a lot here to think about as possible targets going forward. And that's exciting because you would want to get as much of the mutant Huntington under control, however that's done, as you can. And it also creates additional challenges because currently approaches that are aimed at mutant Huntington are focusing on the central nervous system by way of access. And so you have studies, as we know, that introduce the therapeutic of interest through a lumbar puncture. And there are other studies that introduce it directly into the brain, Unicure study, Voyager. And so if you can get it into the brain, it's a good start, right? Now, how would that go for the liver? How would that go for the heart? How would that go for something as diffuse as white blood cells or the immune system? So these are new challenges to be met if there's reason to believe that therapeutic targets are emerging. So this is very cool. There's a lot of room to improve things and learn. And so there will be more coming in this space. There are two more, not on this slide, that I wanted to talk to you about, because we have specific evidence that suggests that we should investigate this. And so we are. And I want to let you know what that's about, because you can probably jump in and help. We'll talk about that in the end. So hormones appear to change in Huntington's as well. There's an association between glucose intolerance and diabetes. Some data sets suggest that diabetes, as Huntington's evolves, is substantially more common than age-matched controls. It's less strong in other data sets. There's suggestion of insulin resistance in animal models. And there's some hint that there's something going on here, which in some ways makes sense, because if you think about Huntington's disease as it's evolving, people are losing weight no matter what they eat. And so, Amy, you know too that when people are starting to lose weight, you know, the liberality about diet, you know, small frequent meals, you know, as you mentioned in your talk, but also the content, high calorie, high calorie, high calorie. We recommend that because it tends to, in some ways, promote at least energetic efficiency, right? There's more calories and fat per unit consumption than there are in other things like carbohydrates or protein. So we want to get those calories in there so that energetic needs are met. But what if you're inefficient? What if you're putting all that raw fuel in and it doesn't actually matter what's happening behind the scenes and how it's being used? And so you have this frustrating experience where people lose weight, and at the same time, no matter what you do calorically, you're not really gaining traction. So there's something about energetic metabolism that is clearly going on peripherally in Huntington's disease. And this is why we're so interested in the metabolome and why we think there's clues in there about how to potentially modify diet or possibly modify the machinery however that could be, and try to improve this. Because as you're hearing, Huntington's is way more than just the brain. So we have work to do. Testosterone levels are lower in men. Small study, hard to draw a conclusion, really, but interesting. Hard to really say whether that's the disease or otherwise in a small sample, but suggestion that it may be there. And this is interesting too. There appears to be a relationship between an important protein called neuroglobin that responds to oxidative stress. So if the cell is being stressed, neuroglobin has a role in attenuating that. Neuroglobin looks like it has a relationship with Huntington. So if Huntington is going down in this estrogen dependent way, and neuroglobin then can't do its job, you might imagine that if neuroglobin needs both estrogen and Huntington to do its job, and it's not getting Huntington, it can't do its job. And so if this is particularly relevant in people with estrogen, namely female, you might imagine that that could have some relevance for progression. This is speculative, but there's data that suggests that this process in animal models might be actually relevant. And so overall, we don't know enough about testosterone, progesterone, or estrogen in HD. There are no longitudinal normalized data sets that tell you what to expect. And it's already a little bit of a tricky issue because when you go and look at what the ranges are for these hormones in people at large without HD, they're fairly wide. It depends. It depends on your age. For females, it depends on your menstruation status, where you are in that. And so there's a lot to think about in whether or not something's normal or abnormal. But in our 2CARE study, we looked at how people did as they went, and we were interested in whether there were things about them that we could measure at the beginning that predicted how they did as they went through the study. And in a way that we're not yet understanding, it looks like women progressed faster than men. Now, whether that has anything to do with hormones, we don't know, but that is one of the main differentiating factors from a hormonal standpoint between people who gonadally have testicles versus ovaries. They make different compounds, they create different phenotypes. We have both of those phenotypes in the study. They appear to progress differently. So it stood out, and we don't know why. And so we would like to try and figure that out. The next series of hormones, if you'd like, that were worth talking about relate to GI function. Now, this is really not understood much at all, but we know that in Huntington's GI function clearly changes, right? So we talked about weight loss. It's not uncommon for people to feel irritated or bloated. We know that as a function of nutritional status going down, perhaps through oral intake. Nutritional deficiencies can become more common. So as Amy was saying earlier, we're very interested in how it is that people are managing their diet to help manage optimal nutrition. Whether or not the gut microbiome has anything to do with this is not immediately clear, but it's drawn a lot of attention in other conditions like Parkinson's disease and Alzheimer's disease. And in Parkinson's disease, it's quite interesting because there's some consideration as to whether there's something in the gut that might actually relate to disease onset and progression. Something in the gut, in other words, that might influence whether or not the abnormal protein of interest, the protein in question, which is called alpha-synuclein, might be influenced by what's going on in the gut as it works its way on up towards the brain. There's suggestion that Parkinson's disease may start in the periphery, in part because early, before people walk in and ask, why am I doing that? They often have changes in their smell, which is closely interfaced with the external environment, and the gut, which is also closely interfaced with the external environment. When we eat and what we eat goes into the gut, that's a close interface. So people wondered if there's something in the environment then that has influenced the nervous system at these proximal points of entry, your nose, your airway, and your gut when you eat. So it's gotten a lot of interest in Parkinson's. No one really knows whether that's true in Huntington's disease. There's something about the gut and the bacteria in your gut that influence how mutant Huntington might be behaving. Because remember, mutant Huntington is everywhere. It's not just in the brain, right? And so whether or not that's relevant to the gut is not clear. Whether it's mutant Huntington is present in sufficient amounts in the gut, whether it would make a difference, whether it's modified depending on what bacteria are there, none of that is known. And so this is a ripe area, I think, to explore what it is that's going on in the gut. Now, interestingly, Julie Stout, who's one of the great cognitive researchers in Huntington's disease, and her group looked at gut bacteria in people with Huntington's disease, and also people with gene carriers who were early in their evolution, and noticed that there was some difference between both the species that were present and also some associations between cognitive performance and the gut bacteria that were there. Now, because you don't know specifically how the bacteria are influencing the outcome, you don't know whether this is cause or consequence. So you don't know specifically if the bacteria are doing something formally to influence the outcome, or whether it turns out that you would have that outcome anyway, irrespective of a bacteria. So there's this cause or consequence question when you make observations. And observations then drive hypotheses, and a hypothesis can then drive an intervention. In other words, if there is a relationship between a type of bacteria, cognitive performance, you might posit that altering the bacteria, however one would do that, maybe a selective antibiotic, maybe something in the diet, might influence the outcome. So these things go in order. You make observations, you generate hypotheses, and then you test them. And that's what science is. So we don't know. Maybe there's something interesting that would be easy to modify in the gut that might have an influence on how people experience their Huntington's. So as you know, as I always like to say, this is how we learn things, right? Research is the way that we make things better, and how we develop treatments, and how we increase our understanding and what's going on. And so all of this that I've mentioned to you, I think to our group is particularly thought-provoking because there might be low-hanging fruit here. You can replace hormones in humans. Testosterone can be supplemented, estrogen can be supplemented. You can modify diet. So if there's something about the gut bacteria and how they are changing their processing of the metabolome, and that's, say, harming people with Huntington's disease, you may want to limit that. So you may actually have to augment someone's diet by taking away. Or it might be the opposite. There might be something about the gut bacteria that, in a way, is trying to compensate. And you may want to see that and increase it. And in that instance, you would be adding. So what to do depends on what we find. And so what we'd like to do is actually think more about this. So we have two trials that were just approved by the IRB. Well, one that was just approved by the IRB, and one is basically approved by the IRB. I think we have just housekeeping work for the approval. The IRB is the Institutional Review Board. They're the people at an academic place like Cooper that look at what you want to do, and they decide that it's acceptable from a safety standpoint, that risks are justified. And what's nice about these studies is they're very simple. So the risk is really very low. The longitudinal hormone study is one where we want to follow how people move through time over 2 years. We want to measure people with the Unified Huntington's Disease Rating Scale over a 2-year period. There's 3 visits that involve a blood draw. So at baseline, 1 year out, and 2 years out, where we'll be looking at hormone levels in men and women who participate. And we'll also be following at 6 months and 18 months with clinical visits. There's not blood draws there, but we're putting together a plot of how people are feeling clinically, and we're also drawing blood to measure hormones to relate to that. So that's the first study. It's very simple. The visits will be short. The only invasive component is a blood draw. The second study is even shorter. It's actually really only 1 visit. What we're looking at is the microbiome. So those are the bacteria again in the gut. And what we want to do is see all comers for TFC 6 and above. So, you know, the total functional capacity score is the way that we measure how you're doing, the things that you're able to do. And that ranges from 0 to 13. And so from above 6 on up to 13, we're interested in seeing what it is that people look like with the UHDRS, and also asking them for a stool sample, which on its face seems like an unconventional experience, but is actually very easy. There's a kit and a little solvent in there that's a preservative, and one collects just a little bit, and it's stored in the bottom of the vial with the preservative, and that's it. That's brought to clinic within a couple of days, and you have your UHDRS, and that's it. One visit, stool sample, UHDRS, and we're going to look to correlate the bacteria that we find in the stool samples with how people look on the UHDRS. In other words, is there a difference in your bacteria depending on what your TFC score is? If this sounds familiar to approach we've done before in our work, it's because it is, where we've looked at plasma and CSF for different TFC scores, but that was the metabolome. And that was quite interesting, which is why we went ahead and looked at additional plasma, which is the study I mentioned earlier that we're going to publish. So I hope that this is interesting to you as it is to us. And if you are interested in participating, we designed these to be very low impact. The longitudinal one is 2 years, but the visits are infrequent and they're very short. And the microbiome one is really only that day. You would get the kit in advance for the stool sample. You would bring that to your visit, but it's really just the one visit because this is a cross-sectional study. We're looking at people with different TFCs, so you can do that once in time. It's efficient. Excuse me. So in keeping with our view, both as scientists, clinicians, and also our purview as potentially eventual patients, because we're all human, and at some point, in order to figure things out, you can be on any end of that spectrum. So our view is giving participation in the inquiry is of the highest priority. And we know that the HD community galvanizes very easily and is just as interested in these things as we are. So hopefully in a local level, if this is of interest to you, please let us know. We have the hormone study and the gut study, gut bacteria study. If you're interested, please reach out to Corlin or contact us directly, either Amy or myself. And let's see if we can't make treatments better. So thank you for listening. That's all I had. And I'm happy to take any questions about that if you'd like.
Yeah, thank you very much. Does anybody have any questions?
I can't, you know me, I'm a geek. I can't wait to hear what happened. I never even thought about the hormones. That's actually, if that works, that's fantastic because that's an easy thing to fix, isn't it? Much easier than some of the other stuff.
It's easy to replete. That's right. And
Yeah.
so if you can create a relationship where there's reason to believe that the levels correlate to people feeling worse, your next question would be in a clinical trial context, which would also be, I think, generally safe to do since these would be FDA approved compounds you'd be testing. So
Yeah.
I don't think there'd be a lot of regulatory hurdles from that perspective.
And are some of the compounds, I mean, like some of the, when you start talking about hormone therapy and replacement therapy, a lot of them are already cleared by the FDA too, right?
Right.
You would just have to use a new designation, which would get it faster.
Well, it's a
Or
good
no,
question.
like how would you do that?
So what
Like
might
walking
happen?
down the road.
Yeah, no, it's an interesting question. So if you go to the FDA and you want to change what's called the indication, meaning
Yeah.
you want that in the label, so that if a physician opens the label, you know, the package insert that comes with the drug, it's actually listed as one of the things it's for. That's in some ways different than if you just want to investigate out of scientific interest. And
Right.
so something like Premarin or any number of them that are already approved for other things, they're
Yeah.
labeled for other things, could possibly be used in what's called an off-label fashion because it's not actually in the label.
Yeah.
So the FDA wasn't formally asked to evaluate it that way. So drugs can be tested off-label for other things, and they often are useful for many things. You know,
Yeah.
this is true of a lot of the drugs we use. So I think what we would want to do, if this was suggestive, would be to test the idea that some people got supplementation and others didn't. And you'd have to design the study to be what we call properly powered, which, you know, Stacy, you have to be able to determine whether there's a reasonable likelihood that what you're seeing is actually true signal. You know, and a study that's too small, randomness becomes more of an issue. A study that's larger and what we call properly powered, able to actually detect true signal, is something that we'd want to do. And that would be a lovely problem to have, designing that study.
Yeah, absolutely.
So we want to test the idea that this is
Yeah.
continuing, in part for what you said, for the very reason you said, is that it would not require the development of an exotic or dangerous therapeutic. You know, none of the drugs that are used for hormone supplementation are risk-free, but they have an acceptable risk profile per their FDA adjudication, which makes it easier to justify trying them, as you said.
Absolutely. How many people are you guys looking to enroll in those trials? Both of them.
So good question. The hormone study is 18. So we're looking for 9 men and 9 women, in part because the ranges are so large for the hormones, and powering that to see a difference would be a really large study, which would be cumbersome, but we think we can see enough if we have 9 men and 9 women to get an idea. And the microbiome study, just because there's so many bacteria, that's a little bit bigger. We're using a genetic technique to analyze the identity of the bacteria. And each of the TFC levels has 6 people, I think. So I think we need 54 total, including a healthy control group.
So Faye had just asked, what stage of HD do people need to be in each of the studies?
So for the microbiome study, it would be 6 and above. And for the hormone study, I don't remember if we excluded it. I think it might be 6 or 7 if we did, but I have to go back. It's not restrictive. So we don't have like 11 or 12. You know, we made it fairly, I think, broad, because we want to see people, if they evolve over 2 years, we want that to be reasonable for them to participate. So if someone's having a tough go, 2 years is a long time, it might be hard for them to participate. So if we did put a bottom, and I can look this up, I'm sorry, I don't remember. I think it might be 6 or 7, similar to the microbiome study.
And that would be more of like a mid stage. Would that
Yeah.
be? Okay.
Yeah, so the TFC is divided into 5 stages. The 5th one doesn't really get thought about very much, but early HD would be 7 to 10. Or excuse me, 11 to 13 would be 1, and then HD2 would be 7 to 10, and 6 is right on the border of HD3. So what we're looking at is very early HD3, HD2, and HD1. So basically early to moderate disease, as you're saying, Corlin. So early moderate would be, say, 6 to 10, right?
Okay. All right, great. Thank you.
Sure.
Anybody else have any other questions?
I can't wait to find your results. I can't wait to watch the study unfold. It's fascinating.
We're very
Good
curious.
luck with it. I mean, God,
Thank you.
yeah, great. You always come up with these. God, I would love to be around your dinner table on a Sunday.
Same mundane stuff every day. Where am I supposed to be tomorrow? Same as everybody, Stacy. The fun, though, is talking to patients, though. Because when the patients are, and this, I think, dovetails with what William Osler said so many years ago about being a clinician. He said, listen carefully to the patient. They're telling you what's wrong. And so when you think about research, these are questions that are driven by our insufficiencies, right? If someone walked in 2 years ago and asked me about hormones in HD, I can't say I'd have really thought about it. I would have remembered that there's mutant Huntington and testicular tissue, but I hadn't thought, well, does that have implications for quality of life? Does that mean anything for, say, muscle mass and fall risk? You can think of all the ways that the other things in the body have to do with how you function. And this sort of dawned on us as a scientific community relatively recently, in a more meaningful way. There's more to this in the other tissues where we can see that there's abnormal Huntington 2. What's even more interesting is that the tissue type might be more severely damaged in some instances than others. So there might actually be tissues where mutant Huntington is relatively quiet, where it's not actually, say, expanding. And there might be other tissues where, for whatever reason, it's expanding fairly quickly. Of course, where it expands the quickest is in the brain, which is why the way that you can see Huntington's is primarily through the nervous system and its function. But that doesn't mean there aren't other things going on. And what we'll, I think, gradually understand is the tissues that are more susceptible than not, and who in whom that is more relevant. So does it have a profile over time, where as people get older, these things become more visible? Are there things that appear late? Are there things that appear early? You know, we have to sort out when these problems actually avail themselves and what their trajectory is as they go. So there's a lot to do. And this is how we start. We start by observing, and then we generate hypotheses, and then we test them. That's the next thing that you do, is actually test your hypothesis, mindful that you could easily be wrong, and you have to then modify your hypothesis or go back to the observation stage.
It's great. It's great.
All right, thank you so much for your time today. Thank you all for your time today.
And you know what? I'm so glad that the RHD patients have you both as physicians and doctors down there, because you guys are both incredible and you give us hope. So thank you, both of you.
It's a pleasure and a privilege. Thank you. You bet, Stacey.
Yeah, absolutely. Thank you.
All right. Well, then on that note, again, thank you, Dr. McGarry. Thank you, Dr. Coulter. And thank you, Dr. Waterman, for your participation today. All of your wise words.
I'm a pretend doctor, a PhD, not an MD.
Still a lot of work.
You're not a real doctor.
Yeah. So, you know, again, appreciate it. If anybody has any questions, any concerns, please feel free to reach out to anybody here on the board. And this will be posted. So you can feel free to watch it again. Yeah, just let us know if you need anything. And advocacy.
If you need slides, let us know too.
Your
Yeah.
congressperson. So excellent. All right. Well,
Thanks, Garland. Thank you.
Thank you, Coraline.
everybody.
Oh, you're back. Thank you.